Central cord syndrome, CCS, is the most common incomplete cervical spinal cord injury, classically occurring after a hyperextension mechanism, particularly in older patients with cervical spondylosis, but it can also follow trauma, acute disc herniation, or central cord edema or hemorrhage. The hallmark clinical feature is motor weakness that is more severe in the upper extremities than in the lower extremities, often accompanied by variable sensory deficits and transient bladder dysfunction. The central involvement seen in central cord syndrome is not random. The central spinal cord is preferentially injured because hyperextension creates an anterior-posterior pincer effect, which is coupled with the fact that central gray matter has high metabolic vulnerability, and the central cord occupies a vascular watershed zone more sensitive to ischemic damage. Additionally, the cervical spinal cord has the largest cross-sectional diameter and is the most mobile segment. Together, these factors make the center of the cord the weakest point during hyperextension injuries. The characteristic neurological pattern of CCS is best understood through spinal cord neuroanatomy and tract somatotopy. In the cervical spinal cord, the lateral corticospinal tract is organized such that medial fibers supply the upper extremities, while lateral fibers supply the lower extremities. A centrally located lesion therefore preferentially injures the medial corticospinal fibers, resulting in disproportionate weakness of the hands and arms with relative preservation of lower limb strength. This explains why hand function is most severely affected, and why fine motor control is particularly impaired. Sensory findings in central cord syndrome are variable but also anatomically predictable. The spinothalamic tract fibers, which carry pain and temperature sensation, cross the midline through the anterior white commissure, a structure located centrally within the cord. Injury to this region disrupts the decussating fibers, producing bilateral segmental loss of pain and temperature sensation, often in a cape-like distribution over the shoulders and upper limbs. In contrast, the dorsal columns, which transmit proprioception and vibration sense, are located posteriorly and are often spared, resulting in sensory dissociation. A key feature of central cord syndrome is sacral sparing, which reflects the peripheral location of sacral fibers within both the corticospinal and spinothalamic tracts, an important clinical sign indicating an incomplete spinal cord injury. Autonomic dysfunction, particularly urinary retention, is common in the acute phase due to disruption of descending autonomic pathways. This bladder involvement is typically transient, with recovery occurring as spinal shock resolves. The pattern of neurological recovery in central cord syndrome also follows a predictable sequence. Lower extremity function recovers first, followed by bladder control, then proximal upper limb strength, while hand function recovers last. This video is a product of the 3D Atlas of Neurological Surgery platform.